Hello, I'm Dr. Gurám Khārzānaśvili. Thank you very much for the nice invitation to participate in this very important meeting. And I would like to discuss with you prostate cancer from early detection to early stage cancer management. Prostate cancer, we know, is the most frequently diagnosed oncologic disease after skin cancer. Prostate cancer is the second leading cause of oncological death in men. 1 in 7 men will be diagnosed with prostate cancer at some point during their lifetime. United States Preventive Services Task Force recommended against PSA-based prostate cancer screening in May 2012 because screening offers small potential benefit from reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening. It is assumed that prostate cancer is not a fatal disease. Many men will never suffer from it. However, so is it. Incidental prostate cancer autopsy overcomes 50%. 11% cancer deaths of all male cancers are prostate cancer related. So, same name, but different disease. What happened after less screening? The disease is diagnosed in advanced stages. Cure is more difficult and more toxic. More patients are primarily diagnosed at metastatic stage. Overall, the ever-declining mortality rates from prostate cancer has come to stop, and in some countries like USA, prostate cancer mortality starts to rise. This was reported at European Prostate Cancer Awareness Day 3 years ago, and the results are here. The new recommendation on prostate cancer screening came from European Commission a few days ago. New screening tests and protocols have been validated and introduced in the member states, and new evidence supports the extension of screening recommendation to other cancers that covered by recommendation 2003. Therefore, extending cancer screening programs to lung and prostate cancer is recommended now by European Commission. Prostate cancer risk adopted strategies recommended by guidelines. It undermines, of course, PSA testing, but with low normal values, risk calculators, MRI and reflex tests, which are not well established yet. If prostate cancer risk is increased, then MRI pathway is recommended, which undermines MRI-based biopsy decision-making and MRI-based targeted fusion biopsy. Why normal PSA value are introduced? Because low PSA values does not guarantee absence of prostate cancer, also absence of clinically significant prostate cancer, as we can see here. European guidelines produce weak recommendations for offering of risk-adapted strategies, lower PSA cutoff values. Here we see here 1 and 2 nanogram milliliters. MRI pathway contains weaknesses which were analyzed by coherent database and systemic reviews. It was revealed that MRI pathway and systemic biopsy missed considerable proportions of grade 2 or higher prostate cancer. MRI pathway relies on experience and skills in reading MRI and targeting biopsy. MRI pathway beneficially miss more grade 1 prostate cancer than systemic biopsy. Assumption of cost effectiveness of MRI pathway may be incorrect. So coherent review conclusion is further improvement of the prostate cancer diagnostic pathway should be pursued. MRI pathway other weaknesses includes lack of live MRI targeting during prostate cancer, high cost of routine MRI, allergic reactions of kidney problems, preventing the use of contrast media, claustrophobia or back pain during the long diagnostic procedure, joint or other implants in the body, and delay in prostate cancer detection. So MRI adds complexity to the prostate cancer detection pathway and limits its accessibility to men. The first in the world 29 megahertz micro-ultrasound system has been introduced by Exent Imaging Canada. This system allows 300% improved image compared to conventional transrectal ultrasound. Live targeting for precise prostate biopsy, transrectal and transperineal targeting, and cognitive MRI fusion platform. Recently, two large review papers compared MRI and micro-ultrasound effectiveness in prostate cancer detection, and it was found that their effectiveness are comparable. At this picture on the left side, we see MRI image and prostate cancer is here located, and on the right side we see micro-ultrasound image and prostate cancer. This is prostate capsule, this is prostate cancer margins, so we see the image is very precise. Can micro-ultrasound pathway be used for prostate cancer detection? Question. We use micro-ultrasound pathway for prostate cancer early detection in routine clinical practice. During 2 years, we did about 1,000 micro-ultrasound targeted prostate biopsies. The analysis of 230 of 1,000 micro-ultrasound targeted prostate biopsies were published last year. Sensitivity and negative predictive value of micro-ultrasound equal to 97%, which allowed 42% reduction of unnecessary biopsies with 3% risk of missing clinically significant prostate cancers. This is a transrectal micro-ultrasound targeted prostate biopsy. Here is the prostate. This is the needle entering into the prostate via rectum. Here is a live targeted micro-ultrasound based transperineal prostate biopsy, which is routinely performed in MMT hospital. We can see very nicely the target in the prostate. This is prostate, and this is target, and this is needle entering the target. The treatment modalities for early stage prostate cancer includes active surveillance, radical prostatectomy, radical therapy, brachytherapy, focal therapy. Unfortunately, discontinuation of active surveillance reached 51% after 4 years of follow-up. Radiation therapy represents the standard of care. However, the radiation dose escalation is crucial for control of the cancer. Protection of healthy tissue from increased doses of radiation damage is essential. New radiation therapy modalities such as intensity modulated radiation therapy, volume modulated, and image guided radiation therapies are not free of healthy tissue damage. Standard radiation therapy often is combined with hormonal therapy, which also might be tied with a number of side effects. Low dose brachytherapy can be offered to men with low and favorable intermediate risk of prostate cancer, but good urinary function is necessary. The reported incidence of acute and late grade 2 or above urinary bowel and sexual side effects is very variable across the literature. The learning curve and the implant quality, have a clinical impact of on toxicity outcomes. Technical challenge can occur during the procedure. Careful planning of seed placement and seed deposition is required for lower incidence of urinary and gastrointestinal toxicity. Radical prostatectomy, we all know, is standard of care. Open radical prostatectomy was popularized by Dr. Walsh in 1982. The laparoscopic approach was first reported in 1997 with the initial 9 cases with average 9.4 hours operation time, indicating significant technical and ergonomic difficulties with laparoscopic radical prostatectomy. The first robot-assisted laparoscopic approach was reported in 2002. Adverse effect of robot-assisted laparoscopic radical prostatectomy and open radical prostatectomy has been compared in non-randomized trial, and incontinence and erectile dysfunction rates were almost the same. So adverse events of standard therapies include radiation proctitis, radiation cystitis, urine incontinence, erectile dysfunction. We need less toxic treatment options for early stage prostate cancer. This option can be provided by focal therapy for prostate cancer. Focal therapies like high frequency focused ultrasound HIFU and cryotherapy are well known and even established treatments. Remaining focal therapies are at early stage of development or less information we have about them. Focal one is the first and only robotic HIFU in the world. It is a non-invasive procedure. We do not touch prostate. It uses no ionizing radiation, but ultrasound, live transrectal ultrasound or ultrasound MRI fusion guidance is available. We can destroy any part of entire prostate or periprostatic tissue or seminal vesicles, and robotic acquisition is available, and this is a single ambulatory procedure. Focal one HIFU is widely adopted in Europe and USA. HIFU treatment is most commonly performed focal therapy in Germany. Focal one HIFU is adopted in leading US hospitals like Cleveland Clinic and California University in 2021. In our hospital, focal one also was adopted in 2021, and we have now about 1.5 year experience of using focal one device. Controversies exist on effectiveness of HIFU in prostate cancer treatment. EU guidelines 2022 describe that problems. Relatively high complication rates for whole gland HIFU. Oncological outcomes for whole gland HIFU are unclear. HIFU focal therapy versus standard treatments. There is a lack of publications. Therefore, European guidelines recommend to offer whole gland focal therapy or focal therapy. I mean, partial destruction of prostate within clinical trial settings. HIFU is not recommended for routine clinical use by EU guidelines, but surprisingly, this recommendation by EU guidelines 2022 is based on few relatively old review publications, which are already 5 and 7 years old. Over the past 5 years, more studies have been investigating HIFU. Recently, 2 extensive review papers have been released. Hopkins et al. Identified 72 papers of focal therapy, and they found that focal therapy improves functional outcomes and minimizes adverse effects. However, oncological effectiveness of focal therapy against the standard of care is still pending. Bekavicius analyzed 20 studies on HIFU, and they found that HIFU offers good preservation of urinary and erectile function. Short-term cancer control rate is encouraging. Focal HIFU has potential to become the standard of care in well-selected patients with prostate cancer. However, in this review papers, analysis of oncologic outcomes is significantly biased because of variable patient ablation protocols. However, these review papers stating that HIFU improves functional outcomes and minimizes adverse events. To assess the true oncologic value of HIFU, it would be fair to evaluate it following total ablation of the gland because of relatively low bias related to HIFU treatment protocols. 21-year oncologic long-term follow-up for whole gland HIFU revealed that whole gland HIFU has good long-term cancer control in low and intermediate risk patients. Also, 7-year follow-up of whole gland HIFU ablation found that whole gland HIFU presents a potential alternative, minimally invasive and safe option for treatment of local prostate cancer. Thus, whole gland HIFU provides good long-term oncologic results in low and intermediate risk prostate cancer patients. And finally, German S3 evidence-based guidelines on focal therapy in localized prostate cancer. This is the first evidence-based guidelines on focal therapy. It is the first guideline around the world which incorporates recommendation for focal therapy, including HIFU. This guideline was issued in 2021. This guideline might also be have an international use. This guideline might also have an international use. Now the use of HIFU is approved by the guideline. German S3 guidelines provide with the indications to focal therapy and with the recommendations for evaluation of these patients. The modern strategy of prostate cancer management concludes early effective detection and effective treatment of early stage prostate cancer. In conclusion, risk-adapted prostate cancer screening and early detection represent the modern strategy in prostate cancer management. Micro-ultrasound has very good potential to be incorporated in prostate cancer screening and early detection programs. HIFU can be safely used for the management of early stage prostate cancer without significant reduction in quality of life. I hope these guys enjoyed modern diagnostic and treatment modalities. Thank you for your attention and goodbye.